Expansion is one of the most common orthodontic topics that is frequently asked in NEET MDS and INICET. Yet, many of us find it confusing because of the different classifications, appliances, and the biological principles involved. Hi, I'm Dr. Varshitha, INICET AIR1 and an orthodontist. In the next few minutes, I'll help you master the complete concepts of expansion in an exam-oriented manner. So, grab your notes, stay focused, and let's get started.
Expansion in orthodontics. Expansion is a procedure that is used to increase transverse width of the dental arches. Expansion can be done both in the maxillary and mandibular arches. Mandibular arch expansion is not done very frequently. Expansion is mainly used to correct transverse maxillary deficiency. Emerson C. Engel was the first person to report transverse maxillary expansion. Hence, he is regarded as the father of rapid maxillary expansion. Before getting into the depth of expansion, let us first understand how and where this expansion occurs. A maxillary expansion is going to occur at the level of mid-palatal suture. How is this mid-palatal suture formed? Mid-palatal suture is formed between the palatal processes of maxilla and the horizontal plates of the palatine bone. As we all know, maxilla is not a standalone bone. It is surrounded by a number of cranial and facial bones. So, any maxillary expansion procedure is not just going to affect the mid-palatal suture, it is also going to affect the circummaxillary suture. As the maxilla is surrounded by a number of other bones, during expansion, the mid-palatal suture is not going to open in a parallel fashion because the surrounding bones are going to offer resistance towards parallel opening of the mid-palatal suture. So how is the mid-palatal suture going to open? It is going to open as if on a hinge, that is in the shape of a triangle or a V, both in the anteroposterior and coronal planes. In the anteroposterior plane, the apex of the triangle is going to face posteriorly and the base of the triangle is going to be anterior. In the coronal plane, the apex of the triangle is going to be at the floor of the nose and the base of the triangle is going to be between the two central incisors. So both in anteroposterior and coronal planes, the wider part is in the anterior region. Since maxillary expansion is occurring at the level of mid-palatal suture, it is essential to know a little about the maturation of the mid-palatal suture because mid-palatal suture is not going to stay the same from birth till adulthood. It is going to undergo 5 stages of maturation. These 5 stages were given based on CBCT findings. Before getting into each of the stages, let me first tell you the landmarks. The entire picture is going to represent the hard palate. This is the incisive foramen. This small line is going to delineate the maxillary bone from the palatine bone. Ahead of this line is the maxillary bone. Behind this line is the palatine bone. And this suture is between the palatal processes of maxilla, and this line is between the horizontal plates of the palatine bone. Now going into the 5 stages, stage A is where the mid-palatal suture is almost a straight high density line with no or little interdigitation. Stage B is where the mid-palatal suture assumes an irregular shape and appears as a scalloped high density line. In stage C, the mid-palatal suture appears as 2 parallel scalloped high density lines that are close to each other. In stage D, the fusion of mid-palatal suture has occurred in the palatine bone. Stage E is where the sutural fusion has progressed from the posterior to the anterior region, and thus the suture has fused in the maxillary bone also. The clinical significance of these stages is that at an younger age, the suture is patent and the bone is less dense, whereas as the suture matures at an older age, the suture becomes more interdigitated, rigid, and finally fuses. So, the sutures will be more responsive to expansion before skeletal maturity. Thus, the ideal age to start expansion in females would be below 16 years and in males would be below 18 years. Now coming to the indications for expansion, maxillary expansion is indicated in cases of posterior crossbite, narrow maxillary arch as a space gaining procedure in cases of mild to moderate crowding, in cases of constricted palate, especially in cleft lip and palate cases, to coordinate the upper and lower arches before orthognathic surgery. Expansion is also used as an aid before attempting maxillary protraction using face mask, and it is also indicated in cases where there is a need to improve the smile aesthetics and buccal corridor. Now let us look into the different types of expansion. Based on the rate of expansion, maxillary expansion can be classified as slow, rapid and semi-rapid. So the activation rate in slow maxillary expansion would be 0.5 to 1 mm per week, in rapid maxillary expansion 0.5 to 1 mm per day, and in semi-rapid maxillary expansion 0.2 to 0.3 mm per day. So the treatment duration for slow maxillary expansion would be long. For rapid maxillary expansion, it would be short, and intermediate for semi-rapid maxillary expansion. And the force levels in slow maxillary expansion would be between 2 to 4 pounds. In rapid maxillary expansion, 10 to 20 pounds. And the force levels would be moderate in semi-rapid maxillary expansion. The relapse tendency in a slow maxillary expansion is relatively lower. They tend to be more stable if the retention is adequate, whereas rapid maxillary expansion shows higher relapse risk without rigid retention. At least 3 months of rigid stabilization is required in cases of rapid maxillary expansion. In semi-rapid maxillary expansion, intermediate stability is there. Now let us look into the different types of appliances for slow and rapid maxillary expansion in the coming slides. Let us start with the slow maxillary expansion appliances. They can broadly be classified into removable and fixed appliances. The removable slow maxillary expansion appliances include removable jack screw appliance, coffin spring, and Schwarz appliance. Fixed slow maxillary expansion appliances include W-arch, quad helix, and Mid-palatal expander. Let us now start with the rapid maxillary expansion appliances. The RMA appliances can broadly be classified into tooth and tissue-borne appliances and tooth-borne appliances. In tooth and tissue-borne appliances, we have the Haas appliance and the Derischweiler appliance. Both of these appliances have an acrylic palatal coverage and they use a jack screw for activation. The disadvantages of these two appliances is that they cause palatal irritation and oral hygiene maintenance is difficult with these two appliances. Second category of appliances include tooth-borne appliances. Examples of these appliances are INICET appliance, which uses a spring-loaded mini expander which provides a continuous expansion force, and the hygienic rapid expander. Both of these appliances have no acrylic palatal coverage, so these two appliances are more comfortable for the patients when compared to the tooth and tissue-borne appliances, and they help in maintaining better oral hygiene. So far, in all the expansion appliances we saw, one common thing was the expansion screw. So this is the expansion screw, which on activating with this activation key will produce expansion. Now coming to the pitch of the expansion screw, pitch is nothing but the distance the screw is going to open on 360-degree rotation, that is with 4 quarter turns. So the pitch of the screw will be 0.8 mm. Basically, it is going to reflect the distance between two consecutive threads in the expansion screw. Once the expansion is done, the appearance of a midline diastema is going to indicate successful expansion. Now let us look into the skeletal and dental effects with rapid and slow maxillary expansion. Let us first see the graph on the left side. Here, the purple line is going to represent total expansion, red line represents skeletal expansion, and the green dotted line represents dental expansion. In the initial phase, that is from week 0 to week 2, there is a sharp increase in the purple line. The total expansion quickly reaches nearly 10 mm. This tells us that rapid expansion works very fast, usually within 1 to 2 weeks. Now look at the red line. Initially, it rises rapidly to around 8 mm. This means most of the expansion is skeletal initially, meaning actual separation of the maxillary bone occurs. So, in rapid expansion, approximately 80% is skeletal change at the time of expansion. But after 2 weeks, we see that the red line decreases slowly. Why? Because the tissues try to pull back the bones. Slight relapse occurs. This is why the appliance is kept for about 10 to 12 weeks as a retention. Now let us go to the green dotted line, which is the dental expansion. So initially the dental movement is very less. Later the teeth begin to tip outward gradually so that the dental contribution increases slowly. Finally, the skeletal expansion becomes around 5 mm and the dental expansion is also around 5 mm and the total expansion remains at 10 mm. Now let us go on to the graph on the right side, which is the effects with slow maxillary expansion. Here we see that all the lines, that is the total expansion, the skeletal and the dental expansion lines increase gradually. There is no sudden jump. So here, both the red and the green lines rise almost equally. This indicates that half of the expansion is skeletal and half is dental. So for 10 mm of expansion, about 5 mm is skeletal and 5 mm is dental in case of slow maxillary expansion. Now going on to the ratios with slow and rapid maxillary expansion. With rapid maxillary expansion, initially the skeletal to dental ratio stays at 4:1 and finally it comes back to 1:1, reflecting equal dental and skeletal contribution towards the total expansion. Whereas in slow maxillary expansion, the ratio of skeletal and dental stays 1:1 from the initial to the end. Next is surgically assisted rapid palatal expansion. So, SARPE is the preferred approach for managing transverse maxillary deficiency in skeletally mature patients where traditional rapid maxillary expansion fails due to the fusion of mid-palatal and circummaxillary suture. Unlike RME in adolescents, SARPE relies on surgical mobilization of the maxillary halves followed by controlled mechanical expansion. So, post-surgical mobilization of the maxilla, after a latency period of 5 to 7 days, activation is done at the rate of 0.5 mm twice daily. And the duration of expansion would be 2 to 3 weeks depending on the required amount of expansion, followed by retention for at least 3 to 6 months. Next is micro-implant assisted rapid palatal expansion, which is going to use mini screw anchorage to reduce the dentoalveolar effects and maximize the skeletal effects. Now let us see the possible complications with any expansion procedure. The possible complications include pain and discomfort, gingival recession, root resorption, palatal tissue irritation, relapse, and asymmetric expansion. One other important complication that is possible is that any rapid maxillary expansion that is carried out at a very younger age, like in case of 5 years of old, it is likely to cause nasal changes like nasal hump and paranasal swellings. So all these complications can be prevented by proper diagnosis, controlled activation, followed by adequate retention phase. To conclude, younger patients will respond better to traditional rapid palatal expansion. Adults show more dental tipping and side effects. MARPE and maxillary skeletal expander will provide better skeletal effects in mature patients. Proper case selection is essential for stable results.